Dr. Grostic was the most amazing person. And what you'll find tonight in the presentation is his intellect, his humor, and just his just pure goodness that just comes through. And I think you'll all agree when you see the presentation. But Dr. Grostic actually, Roger, I think it was 1973, they first proposed this mechanism, from what I understand, the dentate ligament cord distortion hypothesis. It was published in the first issue of the Chiropractic Research Journal in 1988.
You just take the two views. It's not a problem. I've only done it like twice in practice. Thought I only had 2 patients, but if they hadn't both died, I might still be doing this, you know. It's very rare that you do that. I really think I did it on about 2 patients. That was about it. And it's not very common. But that's how you can do it. Okay, we'll go ahead and bring the head clamps down, and then you can move the person laterally to try and center them as best you can between the head clamps. And you want to get the head clamps so they're the same distance from the ears on both sides. And you don't bring them in. I'd keep them about maybe 1 inch, 2 inches away. Also make sure when you bring them down that they will clear the patient's head. I mean, it's embarrassing to have the person so far offside, you're not watching, you bring it down, and this one's out here, but unfortunately that one got him right in the eye, you know. And I've seen that happen. I've seen students do that. Bring the head clamps down and thump, you know. It's not good, because that person is not likely to stand there and let it hit them. They're going to jerk their head out of the way, and when they do that, they're going to bounce it off the bucky and back into the other head clamp. And, you know, it's like getting your head in a cupboard and bumping it, and you know how that goes. You know, it's just, you call it shell shock. You're not sure what's happened. It's an awful experience to have that happen. And sometimes you can't stop it, you know. It just keeps going. Sure, you laugh. You haven't been there.
If you still have spark gaps, you have to adjust or something like that. That's the way they used to do it on X-ray machines. I don't know if you're aware of that, but my father used to take X-rays that way. The way you would set the KVP, you had 2 rods and 2 balls, and you would bring these together until you got the spark to peak at the distance you wanted. So you knew how much kV it took to jump 1 inch, and so you would set these things so far apart to get the right kV, and then you would raise it until it just peaked. So you got just a nice arc peaking in there, and then you had the right voltage, and then you just transfer that to the tube. It's a very simple system. Occasionally people had amazing recoveries. One of my old friends used to tell a story. He died quite a few years ago, but he used to tell a story about this. In the early days, the X-ray equipment was not shockproof. And I'm not talking about that early days. I'm talking the 30s and 40s. It was not shockproof equipment. And that meant that occasionally bad things happened. And he tells us one story about this guy came in with a Thomas collar on, with the steel posts and the whole thing in it, and he put him in the X-ray machine, and all he remembers is pressing the button, because at that point the thing shorted out through the machine and back through the console. And when he came to, he was in the other room on the floor. He'd flown across the room. And he came to, and the patient already was conscious and had his collar off and was turning his head and saying it really felt good. It was very... Thanked him and left. Paid him and left. It did amazing things. Also, there's history. Yeah, there is some history here that's kind of important, because it dictates the views we take to some degree. For instance, we take the vertex view. Why not the base posterior? Well, yeah, that's all after the fact. The reason we started with the vertex view was because there was no way in the world you were going to push a non-shock tube up between somebody's legs. You would zap them every time. See, the idea is you want to keep that tube as far from them as you can. You start bringing that tube up where they're likely to touch it with their knee, they're going to launch themselves. But there are a couple things that you just want to think about, and I'm just kind of bringing these up because these are the worst possible scenarios. You know, nothing ever goes this bad, but if it does, you know, you just close the door and leave. You get in this position and you start to fall. What do you do? Well, it's bad. Now, you got a couple of possibilities. You can do absolutely nothing, in which case you fall on the patient's head and neck. Okay? And then there you are, your head's down there, your feet are sticking up here, and you're lying across the top of the patient, and it doesn't look good. It's probably not going to do that good either. Although you never know, that x-ray treatment works. Okay, so now another option you can do. Here you are, you start to fall. Aha! I will pick this leg up and straddle the patient. We'll pick this leg up and kick them right in the chest. Because their chest is up that high, you can't possibly get your leg over. And so you're going to end up kicking them right in the chest, and then you're going to fall on their head. So that's not a good situation.
I was at Palmer. We did a research project there where we took heads and necks of cadavers, we froze them, and we then cut them into 3 to 5 millimeter sections. Not a pleasant task. In fact, if you get a funny look on your face when you do this, they can take you away. If somebody walks by and you've got a head on top of the thing and you're running it through the bandsaw. And I found out later that after you do this for a while, you do get a funny look on your face.
So she was discharged. And they brought her to the office, and when they brought her out, of course, we would get an x-rays. Now remember, she's non-supported. We had to hold her to get her upright position. We were able to get to, because of the head clamps that we had, we were able to get perfect x-rays of her. She went back that night, we took the x-rays, she went over to the sanitarium, and she had had a tracheotomy and so forth and so on, and she had work being done there. Because this was in a newspaper. This was a public interest story. Every morning they'd have 25th day, 26th day, 27th day of unconsciousness. We adjusted the little girl in the afternoon, and the next morning the mother walked in the room where the child was, and the little girl turned over and said, "Hi, Mom." The first words she'd spoken in 28 or 29 days. 2 weeks later, she walked in the hospital with the mother to pay on the bill, and all the nurses came around as a human interest story. That's to show you the intimidation and the things that happened. The lady who was writing this column in the Constitution is still writing a column in the Constitution every day. And the epilogue, she wanted to get in the paper. She calls the lady that's handling this public interest. This is a public interest story. Says, "Hey, look, my child is well. My child is out of the coma." And guess what the words of the columnist was? "Since you've taken your child out of medical care and put her under chiropractic care, we no longer have any interest in the story." If any of you learned anything about how to place a patient and how to look at film and reason for head placement and for the shoulder placement and what you're visualizing as your problem to solve, this is your problem to solve. When you see these patients come in, you have an obligation. Dr. Grostic used to have his classes. And you'd sign a thing when you came in, and he'd take your money and he'd give you a receipt. He used to start the classes at 8:30 in the morning, and he'd go to maybe 10 o'clock at night. And he never would start a class at 8:45 because he said he had a contract with you. When you take that patient's money, and you take their check, and you write them a receipt, there's a contract between you and them that you're going to render them the best service you know how. And I think the reason you're here today is that most of you are reasonably aware that that's what you want to do, is to offer that kind of service. So if we can help you in any way, let us know. We'll be around the rest of the day.
The cool part about sending Dr. Baker, he works them down so much that I don't usually have to do anything to them except check them and take their money. I was coming back from Orlando. I see some faces. I know some people that were in Orlando. I had Dr. Bo was driving my truck, and I had a voicemail from a patient, and I was just listening to it, and I had it on speakerphone. And the patient says, "Oh, Dr. Umber, just want to thank you so much. I am totally pain-free in my back. You know, I think of everything I've done." He said, "It's just amazing what you've done, and how great I feel." And I'm calling to get Tyler up there, my son, because he's got asthma, and I want to bring him to you. He said you would check him. So I just hung up the phone, Bo looked over at me and said, man, what'd you get her down to? I said, I never adjusted her. What do you mean you never adjusted her? I never adjusted her. I said, Mark Baker, put her on 0. I've checked her 5 times, and she thinks I'm the greatest doctor. True story. Happens more than that. So I told Dr. Baker, I ain't going to brag on him that much, but the truth's the truth. And that we, out of 70 of those patients, I have not had one that did not respond. Now, you tell me somebody has odds like that, and I will take every one of those patients, and you look at every one of those symptoms, with the words that are coming out of my mouth, nothing but truth. And I'm saying, who can beat those odds? If you have 75 patients with different symptoms, and they're all going to get their atlas set, and all the symptoms are resolved for what reason, I mean, the reason they came for. Is that not powerful? Nobody has that except the greatest, one of the greatest healthcare procedures in the world.
Since you know this work as well as you do, I believe you can understand it by me just telling you this. Visualize now if you had an S3 or an S4, and you drove straight down without any anterior stance at all on a hand adjustment or instrument adjustment. Don't you see that that atlas already is biased to turn from anterior to posterior with a high plane line? Remember, you want to turn the atlas like this. Okay, with a straight down, you already have some turning forces in there. You know, with a posterior listing and an S3, you might be driving the atlas at right angles, and you will say that's why posterior is much more difficult to correct than anterior. Now, if you don't understand, if I can't get across it, we may figure out some way to put it on schematics.
Let's get the models of the skull and the bones, just hold them up.
Yeah, we might be able to do this.
That means you have to go
What,
more.
I don't even know what that's not. That's not
From
back
the lateral. No, from the lateral, yeah.
Now,
Just from the lateral.
All right, now look at it like this now. You see this, we got about an S4 or 5 sitting on that atlas now. Okay, now, if you went straight down, you see you would have some rotation factors. See, anterior, you have a lot of, turning like that. So therefore, it makes a difference in how you line up. If you have a high S line or a low S line, suppose you had a flat atlas in there, which I can't get that one all the way flat. Then you would have to go further anterior in order to turn it, because you might be driving in there. But since it's already tilted there, we have straight down movement will have a tendency to turn it for you. Now, if you have an S4 and a posterior 4, and you move back here, you're going to be driving at right angles to the atlas, so you're not going to have any rotation factor. So the posterior is going to be difficult to correct.
What we're going to go over today is some post-X-ray reasoning. Now, one thing I want to emphasize, post-X-ray reasoning has to start with a good pre-X-ray. Does that make sense? If your pre-X-ray isn't clear, if your pre-X-ray isn't good, you have to take it over. If your X-ray equipment's not lined up, you got to get it lined up. Because what you're seeing the first time, how can you reason what went wrong if you don't know what was right to begin with? Say yes or yes. Yes. Okay. So anybody who's got their equipment lined up, got it right, I applaud you. Have it checked periodically, make sure it's good. And if the film, has anyone ever taken the film that wasn't good? Well, if it's not good, throw it away, take another. That's what I say every time. It's never failed. They wonder how they can move when they got the clamps on them. I tell them they move. So, I got a low arch, they got to take it again.
Is 83 years old, and I started looking. I know Wanda Turner, and I know how often she would get checked, and there was times she'd hold adjustment better. She had a lot of head traumas, but I know that looking back at her complaints of her health throughout the years of seeing my dad, I know she was always at that state of dis-ease. If she had not been getting checked probably that often, she'd have had that disease a long time ago and not at 83 years of age. But because he just was there to serve her and adjust her. I mean, in the 5 years that I've gone to that office, Wanda insisted I re-x-ray her at least 7 different times. It's like, Wanda, I don't think you need to be re-x-rayed. She said, I know, I've been doing this long enough. And you know what? She would be right every time, but one time she was right.
In a professional golfer, there's not much difference between Tiger Woods and all the rest of the golfers. You look at their average scores, Tiger Woods maybe 1 stroke better on average than all the rest of the golfers. It's a very small difference. Maybe a 1% difference, a 1.5% difference. But yet he's at the very top, and all the rest of them are somewhere down below. Matter of fact, if you look at the very last place professional golfer, the average score that's posted on the PGA website, you'll see that there's only about 2 or 3 points difference between the average scores between these golfers. The question is, how did Tiger Woods, on average, become that much better than all the rest of them? And he's only a few percentages better. Well, one of the things he does is he can execute the basics flawlessly. He does everything, the basic golf swing, the basic contact point, everything that he does, he's mastered all the basics, and then he's built upon that. That's the problem that a lot of us make is, or a mistake a lot of us make is that we learn a little something, but then we want to go right on to the advanced work and we forget about the basics.
So about that time in '94, there was a brochure out from the ICA on a pediatric diplomate, and I took a 6-mile walk and thought, you know, I think I'll do this. And I really planned to just do a couple of classes. Didn't really plan to do all 3 years, but I'm glad I did. As I went through the program, I did gain a tremendous amount of knowledge about pediatrics. But I didn't learn how to adjust any better. Actually, as I went through the pediatric program, I realized that they all need help with adjusting Atlas. And it was fascinating to me that in the pediatric program, easily the strongest focus is on Atlas. I mean, they say you got to set Atlas before you do anything else. I'm thinking, well, I know how to do that. But, you know, the information that I got from the program was invaluable. There were many things that I learned about that I felt better suited as a parent and also as a provider to take care of kids.
Be quiet in the adjusting room when it's time to adjust them. Okay? Not Dr. Parker, but I have had an associate in the past that quietness is so uncomfortable that you got to keep running your mouth. And yeah, you're going to talk to your patient when they come in, you greet them and you check them, and you can talk all you want. But by God, when you got them on that table and we're right here, that's not the time to be talking about the ball game. That's not the time to be talking about their husband. That's not the time to be talking about the weather. That's the time to be zoned in. You're going to screw something up. I'm just telling you. And you say, well, you know, that's weird. You're being, aloof or whatever. No, the patient appreciates it. Again, it just nails in the seriousness of what you're doing. One thing Dr. John Francis Grostic used to do, that I do almost all the time, is that after he would adjust somebody, he'd put him on the table and he'd leave him there. Usually he would go check another patient. Then he'd come back and he'd pick him up and he'd check him. Well, we could argue about clinically that's good to go ahead and have them relaxed and set, don't have to move their neck after you readjust them. How much of a difference will that make in helping them hold an adjustment? I don't know. Probably not much for most people, is my guess. But what are you doing? You're just drilling in their head the seriousness of something that just happened. In other words, something important just happened. Because you tell them, listen, you might want to lower the headpiece, straighten out whatever, and say, okay, Ms. Jones, be real still, stay right there, don't move, I'll be right back, okay? And you make sure to say, don't move, be real still. And they're thinking there, because people, everybody's different, but most people are thinking, I didn't feel anything, but yeah, I guess maybe he did do something.